There are only two problems in fluid volume. So you see either you don't have enough or you have too much. Let's keep it simple. Here are the causes. We're looking at table 10-4. So for fluid volume deficit, here are the possible causes. So quiz or text or test for exam 1 could be select all and apply, which are possible causes. Here are your answers. And manifestations, here again, weight loss is number 1. What will happen to the skin? Skin turgor, of course, will be decreased or poor. What is oliguria? What is anuria? Let's keep it specific. So oliguria is urine output of less than 400 per day. Anuria is anywhere between 0 to 100 ml per day. I repeat, oliguria. So we can say 101 to 400 is oliguria. Then 0 to 100 ml per day is anuria. Concentrated urine, that means what happens to specific gravity? High, low, or normal? High. Capillary filling time, that means capillary refill is over or less than 3 seconds. Prolonged. Over 3 seconds. Decreased BP, flat neck veins. You can also add there flat hand veins, dizziness, weakness, confusion, tachycardia, muscle cramps, sunken eyes, and here are your labs. All right. Again, very good. Select all that apply type questions. You can also do bow tie. Okay, you've seen bow ties, right? And also drag and drop questions. Bow ties is the bow tie is 3 columns. Bow tie, the center usually is, if it's a bow tie question, it'll give you a scenario. Let's say something like this. You'll have a patient, signs and symptoms, labs.
Boxes.
Yeah, and then you like ask you a choice, give you a drop down of, well, what is the patient's problem? So choices will be fluid volume deficit, fluid volume overload, and then 2 others that are unrelated. So you pick one, drag it to the center. So that's your problem. That's your nursing diagnosis or medical diagnosis. And then either side will either ask you, okay, what will be your supporting, what made you say this is the problem? So it'll ask you, of course, signs and symptoms. So you'll drag signs and symptoms to the left side, and then the right side could either be actions, which is what are your interventions, okay? And then you drag your choices there. Now the number of choices can be either 2 or as many as 4. That's a bow tie question. So it literally is a bow tie. Okay, that's a bow tie, right? Yeah, so it looks like a bow tie. Does that make sense? Okay. A drag and drop, it's like a multiple select. Yeah, that same thing, like a bow tie. But for drag and drop, you either have 2 columns, usually 2 columns. Okay, drag these manifestations. So let's say I can put this as a drag and drop question. So drag manifestations or findings or lab results for dehydration on the left column, and then right column fluid overload. Okay, and then you drag. All right, simple. This it's a fun way to test. Okay, for fluid overload, these are your causes, and also your pretty much opposite what you saw in dehydration. Right, so I won't read it for you. It's all laid out here. But please be mindful that on the exam, it may not be exactly like this. So instead of just low or high, I'll give you numbers. All right. Yeah, so hemoglobin will be this, hematocrit will be, let's say 52%, all right? So it'll actually be values, all right? Including urine specific gravity or osmolarity, for instance, you'll see numbers, all right? Okay, so here's the numbers I was blurting out earlier. Oliguria, less than 400, and then anuria, of course, is 0 to 100. Let's go now to interventions. So let's keep it simple. If someone has dehydration, so what will you give? Fluids. Okay. Well, the type will depend on yeah, correct. And I gave you examples earlier. So let's say you have a patient coming in with really low blood pressure, high heart rate, right, which is indicating fluid volume deficit. So what will you give first, blood or IV fluids? Realistically, it'll be IV fluids, right? Because how long will you get blood? At least 30 minutes or maybe an hour. Okay, in emergencies, we can get it in 30 minutes, but under normal circumstances, it will take at least an hour. Okay, because you have to put the order in, blood bank has to take it. They have to thaw the blood, type and cross match the patient. So it takes a while. Okay? So the first option would, of course, be fluids first. And here, you have scenarios also mentioned here. Okay, so please read the details. I won't read the examples for you. Okay, so it lays out here, for instance, if, however, if fluid losses are severe, here. So, because of course we prefer the oral route, but of course the patient's hemodynamically unstable, then can they drink enough? Because what are the manifestations again? Look at here under manifestations. So what does a dehydrated patient look like? Confused. So therefore, can they follow directions to drink fluids? Okay. Or are they well enough to drink fluids? Maybe they're unconscious, right? The blood pressure is low. So therefore, IV route is preferred. So this is what I mean by please read the details. Okay, I won't read them for you. We don't have time to read them in class. Of course, whenever you give something, you have to evaluate, right? Because are we going to give IV fluids forever? How do you know it's time to stop the interventions? Assess the same things you assessed before the interventions. Okay, so if the findings are now normal, do we need to continue? No. Now, of course, the interventions mentioned here does not mention anything about the causes. Okay, by causes, what I mean by causes is look at the second column here. Now, the interventions mentioned in this chapter is simply for the dehydration. Now, don't expect interventions for these causes. Make sense? Meaning this chapter 10 only addresses the dehydration and the fluid overload later. Okay, it does not address, let's say, from the excessive sweating, from the burns, diabetes, etc. Okay, they're found in other chapters. All right, so this chapter only addresses what? Just the dehydration, never addresses the cause. Because can we just keep doing the interventions for the dehydration or fluid overload? Of course, you have to address the causes. Okay, again, this is outside the scope of this chapter. Make sense? Which is the case in most chapters. Okay, so chapters are fragmented, meaning they will only address the problem here, not necessarily the cause that led to it. All right. So for instance, when we talk about burns next semester, will they make references to chapter 10? Yes or no? Yes, because a burn patient is a dehydrated patient, okay? A shock patient, a patient in shock, okay? Losing so much water. So of course they'll refer you to chapter 10, because they don't want to keep repeating same interventions because it's already mentioned in chapter 10, all right? So keep in mind, we have to know when to stop. The interventions have to stop at some point and then discharge the patient. Okay, so it requires the same assessments. Okay, so where are we now? So the hematocrit at the beginning was 58 before you started the fluids. You're giving fluids now for 12 hours, 16 hours. How do you know it's time to stop? Hematocrit is now normal. All right. Okay, so here's the solutions finally. It's I didn't realize it's so far. Okay, so it's on page 235. So here are your examples. Okay, so isotonic, LR, D5W, then you have your hypo and hypertonic solutions. Got it? Okay, so it is on its own table. 10-5. You like tables yet? Very nice, yeah. Organizes your information. Okay. Any question on, so here's the numbers I was mentioning earlier. What is 1 pound again? 1 pound is equivalent to 500 ml, 1 kilogram equals 1 liter. Okay, so it's right here. Okay. We're still in chapter 10, same chapter.
What's the title of?
Fluid electrolytes. Okay, let's go to fluid overload. So the manifestations causes are already on the previous table, 10-4 was it? Interventions are here. So of course, what's the intervention? Now the patient has too much fluid. So what do we do with fluids? Absolutely nothing. No fluids whatsoever.
The patient has too much fluid.
Yeah. So what do we do? Fluid wise. What about fluid intake? 0. Remember there. Okay. So what? Make up your mind. So do we give fluids or not? How much? Okay, so there's fluid restriction, correct? How much restriction? Who decides the restriction again? Okay, the doctor will have to make that decision, make that judgment. So they will consider insensible fluid loss because remember, they are still losing fluid, okay, even if they're in fluid overload. Remember, there is fluid, insensible fluid loss, okay, from talking, from chemical reactions, and also from the feces, okay? So fluid restriction, and then drugs. So you mentioned diuretics. Okay, so what type of diuretic? Again, depending on what was the nature of the problem. How did the patient end up in fluid overload? Doctor makes the decision, chooses the appropriate diuretics, and how much of it to give, how often. If needed, the patient may have short-term dialysis. We'll discuss dialysis next week. And fluid restriction and also salt restriction. Here are details about how much salt restriction to give. Here, foods high in sodium must be avoided. Here are options because do you like to eat with no salt? Want to eat paper? No, nobody wants to eat with no flavor, right? So here are options to use instead. Instead of salt, then you have lemon juice or Mrs. Dash, right? But be careful, Mrs. Dash, which is a salt substitute, contains what? Potassium. It's a salt substitute, so there's no sodium, but it contains what instead? Potassium. That could be a problem with heart patients or patients taking certain medications. What type of diuretic is it that causes hyperkalemia? Back in farm. Thiazides and loops all cause hypokalemia. Which one causes hyper? Starts with an S. Spironolactone. All right. Right here, spironolactone. Okay. And same thing. So when we're giving diuretics, we're implementing salt and water restriction. So how do we know it's time to stop? Assess again, same things as before, just like what we did with fluid deficit patients. Okay, never forget evaluation, right? Very important. It's as important as assessment and interventions. Okay, there has to be evaluation. Like I mentioned earlier, whenever you do something or not do something, there are effects, there are consequences of your action or inaction, right? And then you're equally responsible for that. And that's what you're paid to do. All right, they keep mentioning this, so they keep repeating this fluid, this weight equivalent. And here's prevention, of course, which is better than the problem starting in the first place. Here's a term for head to toe edema or fluid overload, anasarca. Okay, we see these in our heart failure patients, sometimes also in adrenal problems, as well as in kidney problems. They literally have head to toe edema. So burns we'll test next semester. We're not taking burns this term. Ascites if the fluid is in the abdominal cavity. All right, any questions? All right, so let's talk about electrolyte imbalances now. So as I mentioned earlier, we're only doing sodium and potassium. So let's start with sodium imbalances. So just like fluid volume problems, we have dehydration and overload, right? So sodium and potassium problems, we either have not enough or too much sodium, not enough or too much potassium. Okay, the way you remember this is either you memorize or you understand what is the function of sodium. That way, when you say deficit or overload, then you can easily or make it easier to remember. Generally speaking, electrolytes are either positively or negatively charged ions, correct? So the job of electrolytes are to generate electricity because of their positive or negative charge. They excite cells, okay, depending on the body system. Okay, so what is sodium? It's found more, they're both found inside and outside the cell, but they're more found or abundant outside the cell. So this is the major extracellular cation. And these are the body systems regulating sodium. So we mentioned the RAS system earlier. We'll talk about SIADH shortly before we end today. For sodium, we will only test because this is chapter 10, we will only test the manifestations, okay? Only the findings, because the interventions vary depending on the problem. So if you look at table 10-6, so these are the causes of hyponatremia. Now, the interventions vary, meaning there's no uniform interventions for hyponatremia. It really depends what is the cause of this patient's hyponatremia. Okay, since it's not discussed here, again, they vary. I won't test that. Okay, so we'll just discuss it as we get to the individual chapters. So what am I testing again for hyponatremia? Only the manifestations. So here, they're in table 10-6, and here are your manifestations. Now look for a pattern. So remember that sodium is a extracellular cation. It's an extracellular electrolyte. So what happens if you don't have enough of it? Look at the pattern. What happens to the cellular excitation? So when you say anorexia, nausea, vomiting, what is the effect of low sodium on the GI tract? So if you don't have any appetite, you have nausea and you're vomiting, what happens to peristalsis? Why do you have these manifestations? Is there peristalsis? There is decreased peristalsis. Okay, so let's move on. Headache. So if remember earlier, we talked about edema. So if sodium is low, according to osmosis, what will happen to the brain cells? If sodium is low, what will happen to the size of your brain cells? According to osmosis, it will cause cerebral edema, wouldn't it? You agree? Okay, so these are now the manifestations of cerebral edema. So you got headache, lethargy, dizziness, confusion. Let's go to your skeletal muscles. What happens to the skeletal muscles with low sodium? Okay, cramps, weakness, muscle twitching. Okay, the seizures here is part of cerebral edema as well. So because cerebral edema, your brain cells are swollen, so what happens to intracranial pressure? It increases. Can that trigger seizures? Yes. And of course, this is your lab findings. Let's go to the excess. So what happens if your sodium levels are too high? Okay, so here are your manifestations. They resemble each other, but there are subtle differences. And then that's it. Again, I won't do interventions because they vary depending on the underlying cause. Let's go to potassium now. Potassium, however, we will do not only manifestations, but also interventions, because regardless of the cause, interventions for low potassium, interventions for high potassium are the same. You understand? Yeah, regardless of the cause. So potassium is the major. So this is the counterpart of sodium. Sodium is the major extracellular cation. This one is the major intracellular cation. So it affects most cells, especially cardiac function, but all cells are dependent on potassium. Whereas look at the sodium function. What is it? What body system is it mostly affecting? Yes, it affects the whole body, but mostly neural, right? Okay, brain. So two problems, either you don't have enough potassium or you have too much potassium. So here are the possible causes for deficit, meaning you're losing fluids, okay? Or you don't have sufficient intake. Now this can be any patient who is NPO for whatever reason. Let's say they're unconscious, not eating, here for a GI problem, or they're having surgery. So of course, no oral intake. What is the only source of potassium? Food and beverage only. You don't eat, you don't drink, of course, where are you gonna get potassium, right? Whereas at least with sodium, we have different, we have stores of sodium. We do not store potassium. The only source again is food and beverages. So since it's a major intracellular cation, so here are your manifestations. So if your potassium is low, every cell excitation is low. So there's muscle weakness, there's little to no peristalsis, okay, so no appetite. Of course, cardiac cells will be weakened. So there will be fibrillation, You have paresthesias. So constipation. To be fair, I won't test the ECG effects part. I'll do this after module 8, which is around week 9, week 10. So all others though are in play. Okay, so I'll test the ECG changes later after module 8. Clear? For hyperkalemia, these are your causes. Especially number 1 cause is kidney failure. So whether it's acute or chronic kidney disease, there is potential for hyperkalemia. Why is that again? Why does potassium levels rise in kidney disease, whether acute or chronic? How do we get rid of potassium? Through the urine via the kidneys. So therefore, kidney function is low, whether acute or chronic. What happens to potassium? It rises, okay? Can't leave the body. Here are your manifestations. So it's usually opposite in all other body functions except in the skeletal muscles. Skeletal muscle weakness is present in both hyper and hypokalemia. In the cardiac function, of course, but like I said, it's not tested yet. So the effect on heart rhythm is not tested yet until we finish module 8. But everything else is, like I said, opposite, except the muscles. Skeletal muscles, the legs, arms are weak in both low and high potassium. And please also remember that is the diaphragm a muscle?
Yes.
Is it affected by potassium levels? Yes. Okay, so respiratory effort here, respiratory function, breathing effort is also affected, which is common in post-op patients. Why are post-op patients very susceptible to hypokalemia? Yeah, post-op patients. Why are they so susceptible to hypo? Were they eating before surgery? Did they eat after surgery? So therefore, what's the only source of potassium again? Exactly. Okay, so very susceptible. Okay, so monitor your post-op patients because it's not like they'll order a hamburger coming out of the surgery, right? You still look measurable. You still feel measurable. You give them a tray. What's the use? I have no appetite. I don't want to eat that. Yeah. They still feel measurable. So very susceptible to hypokalemia. And our elderly also, okay? Dementia patients who don't eat, don't drink, very susceptible. Here's the fact. 80% of the potassium is excreted through the kidneys. The other 20% is through your bowels and through sweat. Now, because of this fact, 80% of your potassium leaves the body. That means, what is your responsibility whenever you give potassium supplements, whether it's PO or IV? What should your assessment be before giving any potassium? How do you know the kidneys are working? What are your parameters? What in the blood? So what will I check? So on open epic, what will I look for? BUN creatinine. What else? Oh, BNPs for the heart. That's heart failure. So what else would let's say I don't have any labs. There's no latest labs. I have a medication. If I order labs, it'll take hours. I need to decide now because the potassium is due. So what else? I don't have a lab, or maybe the lab was 3 days old or 5 days old. Creatinine clearance, again, that's another lab. I have to send a urine sample for that.
So
How would I know? The simplest way. How do I know the kidneys are working? The urine output. Okay. Is the patient peeing? So as I see in the recording, or I see the patient urinating, are the kidneys working? You bet it's working. Okay, so I can give the potassium. All right. So these are practical applications. Okay. So don't just look at it in the textbook. Okay. When you go to clinical, apply. Okay. So are they really look at the textbook, right? Are you having these? Okay, or look at the labs. Oh yeah, son of a bitch. The textbook really is accurate. Okay. It's really what they're showing. Hey, let's go now to the intervention. So we finished the manifestations. Let's look at the interventions. All right. So let's start with hypokalemia. So you don't have enough potassium. So the patient's potassium level is what? Give me numbers. Less than 3.5. Okay, very good. So here are your options. There are only two ways you can give potassium supplements, either by mouth or IV. No other route is available. Again, through oral or IV only. There's no sub-Q, there's no IM potassium. Are we clear? Only, of course, oral available in tablets. There's liquid preparation as well. There's powder. Okay, but only oral or IV. That's it. Now there has to be a guideline here. How much potassium is safe to give? Again, what do we do again before giving in either one? Assess what? Kidney function. Okay, so either BUN creatinine or urinary output. But of course, will you check also the potassium level? Yes, there has to be indication, right? So that's is what you do. Is this appropriate? Should I give this drug? So look at potassium. Oh yeah, potassium's low. I'll give it. But before I give it, check urine function first, because you may start with hypo. Now you give this and then no kidney function. What will your problem be? Hyperkalemia now. Why again? Because 80% of your potassium is excreted by the kidneys. Okay, so no kidney function, then there's no way this potassium will leave the body. All right, so you can do it through food. Okay, so doctor will order high potassium diet. In the case here, again, a reminder, salt substitutes contain potassium, so be careful. Okay, so when the patient is using salt substitutes, especially cheap ones, so the dollar or 99 cents salt substitutes are made of potassium. Okay, there are non-potassium options, but they cost a lot more, like seven instead of a dollar or 99 cents, they're like $7. Okay, that's a lot of money, yeah, for a salt substitute, wouldn't you say? Yeah, and buy eggs instead of just a salt substitute. Spending $7 on this thing. All right, if the IV route is ordered, then there has to be a limit here. Now, the maximum you can give, by the way, IV potassium should always be diluted. Okay, it's always through an infusion. Okay, through an IV infusion. You cannot push IV potassium. Are we clear? What should we not do? Never do? Never push IV potassium. And they should always be what? Diluted. Okay, never given full strength. Are we clear? Okay. If you do either one, undiluted and you push it, this is how we execute people. So capital punishment, death row. This is how it's done. Okay, so we kill them through potassium. Okay, of course we sedate the patient. We sedate them, we give them pain medication, and then we give a lethal dose of KCl push. Okay, that's how execution is done. Okay, that's what we call lethal injection. Okay, so are we doing any lethal injection in the hospital? No. Here we are treating patients. Okay, nobody's being executed. Right. There are many forms of potassium. KCl is the most common, potassium chloride. However, there are different forms. The doctor may order potassium acetate or potassium phosphate. Okay, but in any form, they are always diluted. They are always pre-prepared. Either it's floor stock, meaning let's say there are IV fluids with potassium. There are bags of 10 milliequivalent potassiums already diluted. Okay, so to prevent people from making a mistake, especially new nurses, preventing you from killing your patients accidentally, we do not have access to potassium vials anymore. During my time, we did. Not anymore. Okay, so there are only two places you can see potassium vials. It's in the ER and the pharmacy. I don't even know why they keep them in the ER. They should really be only in the pharmacy. Okay, there is no KCl vial in the crash cart because there's no reason for us to give concentrated potassium at all. Okay, so you'll never see them in the crash cart. What are the two places again? You can only see them? Yeah, not even the OR, only the ER and the pharmacy. It's in the ER just in case they need it fast, but of course they have to be diluted. Okay, we do have reminders, so when you access it from the Pyxis or whatever you use, Omnicell, you know, those medication dispensing systems, if it is available there, there will always be warnings. Never give undiluted. Okay, they should always be diluted. So every nurse should know that. All right. Yeah, here's prevention. Okay, so to correct it, we already discussed PO, but if it's IV, so here's again warnings about kidney function, and also for if it's oral, can produce small bowel lesions, so that's another warning. Okay, so for IV potassium, so never given IV push or IM or sub-Q for that matter. Potassium must be given using a pump. Okay. For concentration, they're available anywhere between 10 to 40. However, I've never seen 40 in 100. So it's only 1:10, meaning for every 10, it's in a 100 ml solution. Are you clear? Meaning 10 milliequivalents is diluted in 100. You'll never see 40 in 100. Right? That will burn like crazy. So the concentration is 10 per 100. The maximum you can give technically is 20, but I have never in my life received such an order. The order we usually receive is 10 milliequivalents per hour, no matter how severe the patient's hypokalemia is. Is that clear? Okay. We can give oral and IV at the same time. We've seen that because they have different rates of absorption, so it's okay. However, if it's IV, okay, only IV, what's the maximum you can give? 10. In practice, 10. In the textbook, some textbooks say up to 20, but in practice, I've never seen an order of 20 per hour. Only 10 per hour. Are we clear? So here again, a reminder, renal function must be monitored. Okay, for anyone receiving potassium, either IV or oral. Any question on hypokalemia? Very good, children. Let's go now to hyper. So for hyper, we finished the manifestations. Let's look at the interventions now. Now we have several options here to correct hyperkalemia. As you can see, because let's say it's IV potassium, since we're limited to 10 milliequivalents per hour, is it easy to correct hypokalemia? You're limited to 10 milliequivalents per hour. Is it easy to correct it? It'll take hours, it'll take days, okay, to correct, depending on how bad hypokalemia is. So therefore, what's the danger here? Let's go back to the manifestations. What's the danger here? Because we cannot correct potassium fast. It'll take hours to days even. What's your number one priority? Among here, look at the manifestations. What's the most life-threatening? The dysrhythmia. So therefore, which order should you carry out first? Cardiac monitoring. So because we cannot, there's no way, it's impossible to correct it quickly. Correction, replacement is very slow, over several hours, over or to a few days. What's the danger there? Can we correct it fast enough? No way, impossible. So until then, what should you monitor? The heart rhythm. So all these patients, will they go on a regular floor? Med-surg floor, they all go to a cardiac unit, okay? So you won't see any hyper or hypokalemia, especially if it's moderate to severe. If it's mild, it's fine. They can go on a med-surg floor. But if it's moderate to severe hypokalemia or hyperkalemia for that matter, everybody goes to a cardiac unit. You need cardiac monitoring, continuous cardiac monitoring. Because why again, especially with hypokalemia? It's not easy to replace. Okay? It's not easy to correct because we're limited by the amount we can give. Okay, let's go now to excess. Straight to the intervention. Management. We have options. Hypokalemia is just as serious as hyperkalemia. Hyperkalemia, as you can see from the manifestations, especially on the ECG effects, it's life-threatening. It can cause cardiac arrest, can cause dysrhythmias. So, there are many ways here we can correct hyperkalemia. Let's begin. In non-acute situations, meaning, what's the level here? Mild, moderate, or severe? Moderate to severe. Mild. Mild hyperkalemia, meaning 5.1 to 5.4, 5.5. Okay, that's mild. So that's non-acute. So we can do restrict dietary potassium, okay, and including salt substitutes, especially salt substitutes. Then we can give a diuretic, okay, potassium wasting instead of a potassium conserving diuretic. So we can give diuretics. You can also give cation exchange resins. This is the oldest drug available, sodium polystyrene sulfonate, more popularly known as K-Exalate. So for those who work in hospitals, you've probably heard K-Exalate. So this is the generic name. Now practice generic names because you'll never see brand names on the NCLEX. Okay? NCLEX uses exclusively generic names only. So SPS is K-Exalate. So this is given by mouth, or if the patient can't tolerate it, or let's say the patient's unconscious or has dementia, won't follow directions, you can give this through an enema. Okay. So what were the ways again we can lose potassium? Potassium leaves the body through how again? 80% through the urine, 20% through the sweat and GI tract, through the bowels. So therefore, what is the effect of SPS therefore? How will the body remove potassium when you take K-Exalate? It will cause a bowel movement. Okay, so SPS can cause diarrhea. Okay, so when you have diarrhea, will you lose potassium? Yes. Okay, so either orally or through an enema. The taste also is not really good. It'll make you vomit. Some patients vomit. It's not a pleasant taste. So yes, I would prefer you give this to me through an enema. Okay, but if the patient's fine with oral, okay, swallow it. Okay, here's a warning. Make sure if you go by this route, there better be peristalsis. No peristalsis, can you give this? Of course, no, it's useless. Okay, plus it will cause harm. Can cause perforation. So here's the rationale. Intestinal perforation can occur. Meaning it'll cause it'll burn a hole through your bowels if there's no peristalsis, okay, for this drug. Here's a newer drug. So I've seen this only in the later editions of the textbook, but in practice, I've never seen this drug, to be honest. I've seen, of course, we see SPS, but I've seen something else, but not patiromer. But I've been seeing this in later textbooks, including this edition. So patiromer is new, but it's like SPS. It's like Kexley. Still works on the GI tract. Now for acute hyperkalemia, meaning moderate to severe, can we still do this? Yes, but the problem with the oral or enema route is it takes 2 hours to begin working. I repeat, SPS and this patiromer takes 2 hours to see effects. Okay, so potassium will not drop if you go by this route. So therefore, are these really options for emergencies, meaning for moderate and severe? No. We'll still give it, don't get me wrong, we'll still give it, but this won't be your priority because why again? Takes too damn long, takes 2 hours to produce an effect. Meanwhile, what will happen during those 2 hours? Patient could go into cardiac arrest. So, in emergencies, here are our options. If you can't remove potassium from the body, then you have to either antagonize its effect by giving another electrolyte, or you can shift it, take it out of the bloodstream, stash it somewhere else momentarily until the oral options work. Again, I repeat. So the oral and enema option, patiromer and SPS, this will remove potassium from the body. It'll remove it. But what's the disadvantage? Takes too damn long, 2 hours or longer. So if you want to lower potassium fast, you have 2 other options. Until you can remove it, you can either antagonize its effect by, again, using another electrolyte to counteract its effect on the heart, or stash it somewhere. Okay, shift it, put it somewhere else. So let's begin. So to antagonize it, we have calcium gluconate. So since your potassium's high, then give a large amount of IV calcium. So within minutes, this will antagonize the action of potassium on the heart. But again, does it decrease potassium? No, potassium remains high, but at least what will it do? Prevents a heart attack, cardiac arrest, okay? Because it will, and what do we mean by antagonize? Does the opposite effect, okay? Opposite effect of potassium, antagonize, okay? But remember, the potassium remains high. So we can give calcium gluconate and then of course, cardiac monitoring, that's a given, right? Another option is sodium bicarbonate. Now, what does sodium bicarbonate do? Okay, let's read. IV administration of sodium bicarb will do what? Shift potassium to where? Into the cell. So bicarbonate will bind potassium, put it into the cell. So therefore, what happens to your serum potassium levels? It'll back to normal. Okay, it'll drop either too low or even at least normal. But did it do the job? Yes, it didn't remove the potassium. Potassium still high in the body, but what did you do to it? You lowered it by shifting it momentarily. Okay, this is again only temporary. So just like IV calcium gluconate, this will work right away. So begin as fast as 30 minutes or 60 minutes, okay, and then last for a few hours. And again, is this permanent? Temporary only. Okay. Another option to shift it. So we have, what's the action of gluconate again? Calcium gluconate? Antagonize. What is the action of bicarbonate? Shift it. And now another shifting option is IV administration of regular insulin and hypertonic dextrose solution. Now, this is not one or the other. Both have to be given. Let me explain why. Regular insulin, IV, this is the only insulin you can give IV. So what's the purpose of administration of regular insulin IV? This will be the one to shift the potassium. So as insulin enters the cell, it takes potassium with it. Do you follow? Okay, so it will shift it, right? Remember, it didn't eliminate. This option will not eliminate potassium. It will only shift it. However, why do we have to give dextrose with the regular insulin? Because what is the effect of insulin? It will drop your sugar. Now, when we have hyperkalemia, does that mean the patient has hyperglycemia?
No.
Not necessarily. So while dropping potassium level by shifting it, what will also drop? Sugar will also drop. So you save the patient from hyperkalemia, but you kill them with hypoglycemia. So therefore, you have to give dextrose with it. Are we clear? Okay, so it's in one solution, okay, one syringe. You combine both, you push IV dextrose or IV regular insulin with dextrose. That way you shift potassium without dropping the glucose. Another option, this one's though, loop diuretics, this will eliminate potassium, okay? Because it will, prevent the kidneys from reabsorbing. But take note though, this option, diuretic option, will not only cause elimination of potassium because it will prevent kidneys from reabsorbing it, other electrolytes will also be affected. Sodium, along with potassium and chloride are also excreted. Are we clear? Okay. Here are other options. So beta-2 agonists like albuterol will decrease potassium. And as mentioned also, we can do, just like with hypervolemia or fluid overload, we can do dialysis. If all the interventions we did, the calcium gluconate, sodium bicarbonate, regular insulin with dextrose, albuterol, did not drop the potassium enough, then we have to do emergency dialysis. But in all these conditions, the patient must be on what monitoring? Continuous cardiac monitoring. Any questions on hyper and hypokalemia? Very good. Okay, so last two topics for today.